We're happy to be joined now by Dr. Charlie Jaynes, an expert in the second victim concept. Welcome.
Thank you. Appreciate
Tell us
it.
what this concept is all about.
Concept started in the early 2000s with Dr. Wu, who had the realization that when something happens untoward in medicine, that there's really nobody to help the second victim, which is quite often and most often the provider. So you have the family and obstetrics, which I practice. When you lose a baby, it's a horrible event for everybody, and people don't account for the fact that it's a horrible event for the provider as well. And it has some pretty wide ramifications for us as well as for the mother and the parents and the family.
So what are you doing here in Texas to do something about it, to help those physicians?
Yeah, our company is located in South Carolina, and we're all over the country, but the idea came from one of our providers in Texas, Dr. Meredith Davenport, who practices here with us in Austin. Had the idea. She picked up about the second victim program from the University of Missouri's work and carried that to the company, and then our HR and risk management department worked with her and developed the program in-house. And we're excited about it. We're talking about assisting our physicians and helping them recover them from the events that have occurred, and then helping to encourage them in their life afterwards.
And this program called CARE, Clinician Assistance Recovery Encouragement.
Right.
So how does it work?
What happens is when we have an untoward event, as in our company, that's reported to a hotline that is set up to be a risk management tool to protect our physicians. And so they call into that hotline and they give a report of what happened in a non-discoverable fashion that can then be evaluated by a risk manager, and that risk manager reaches out back to them. But that also spins off a referral, no matter what the event is, to a care coordinator. That care coordinator then reaches out to that person in an appropriate time frame and asks them if they're interested in having a debrief with somebody from our program. And our counselors, we have about 25 trained counselors, are all physicians. We've all been trained in the aspects of active listening and being able to render emotional first aid. It has nothing to do with us analyzing what happened. It has nothing to do with judgment about what happened to the individual. It simply is listening and empathizing with that person and compassionately caring about them. It's well known that if you have guilt, that's a useful tool.
Yeah.
If you have shame, that's a very degrading tool, and it leads to bad things over a period of time. For us, it's burnout, it's post-traumatic stress disorder, it's even suicide risk. And so we want to try and address that issue for our providers.
What are the things you look for first, those initial symptoms that someone might be exhibiting?
A lot of it starts out just as anxiety, difficulty sleeping, they don't engage well at work, and then it leads to things like depression and post-traumatic stress, where they're reliving the issues and having bouts of unanticipated anxiety. And then the depression can actually lead to suicidal risk. And unfortunately, in our profession, we have a higher risk of suicide than in the normal population, in part because of that. And what I love about this program is that the design allows us to participate in helping that individual without being accusatory, without investigating. We're just there to listen. And when you do that, when you share the shame of an event, then it helps to reduce the trauma of it, and it helps to prevent burnout.
And when do you know when it's time to get help, a physician?
We rely on the individual to tell us that.
Okay.
Now, if we, our team leads are so to speak, the point of our spear in our programs, and if they notice that an individual that previously has been well engaged clinically starts having difficulty making decisions or is having more errors, then they may engage a call to the care coordinator and ask that somebody intervene there.
What about the SAFE report you mentioned?
Yeah, the SAFE report is a process that we use through our malpractice carrier, where when we have an untoward event or we have a win, we have a life save, we pick up a phone and call a 1-800 number and make a report that's then evaluated by a risk manager or certified risk manager, and then they get back to the provider and debrief them on that to store information while it's fresh on their mind, and to see if there's any other things that need to be done in preparation perhaps for a lawsuit later. Or we use that information to report back to the hospital that we had a life save, and that's something that we're proud of, and we want to report that back.
So how can other hospitals or groups around the country replicate CARE, do this type of thing?
I think one important thing is they have to work within the framework of a patient safety organization, because that brings us security where peer-to-peer interaction is not discoverable. And so it allows us to be able to talk, to learn from what's happened, so we can apply that to patient safety in a good fashion. So a patient safety organization, a peer review organization, that's critical. And you have to set that up. We're fortunate that our company had the foresight to have a national affiliation with an organization like that. You have to be very careful in these discussions, but you don't keep notes. It simply is a sympathetic, empathetic exchange between two providers. You can imagine I've done this for a long time, and I have battle scars, and I'm able to share those battle scars with a colleague, and that helps to deflate the shame that comes with the bad events and really helps to improve mental health.
What do you hope your peers here at this conference know about this issue, this second victim?
The second
what should
victim
they take away?
You know, one of my favorite quotes is from the movie Top Gun, and it was what Viper told Maverick after Maverick lost Goose and the airplane crashed, that, you know, a good pilot always is forced to evaluate what's happened to them so that they can use that information they've learned to adapt and change. And the thing I'd add on here is that, you know, adapt and change, but also like yourself and love yourself in the process. That's what we're trying to do. And in medicine, it's a hard profession because you're sort of isolated psychologically when something bad happens. 90% of the time, there's not somebody there to really help, and it has a wide ramification for your family and for your colleagues and your patients. So that's what we're trying to do.
That's what CARE can do, that
Yes.
program can do for people. Dr. Jaynes, thank you so much
My
for your
pleasure.
insight on that.
Thank you for the opportunity.